Welcome back to Therapeutics, the second set of slides talking about antidepressants. And again, I'd like to thank Peter for his support in reviewing and updating some content here. So with the antidepressants, you will see a lot of antidepressants used in practice. I think whether you practice in primary care or whether you practice in other areas, antidepressants, sort of dissimilar from antipsychotics, antidepressants much more widely used for a broadening set of indications and for a more common set of scenarios. And most of the antidepressants that are used in this day and age are considerably safer than the older ones were 3 or 4 decades ago, and also in general probably safer than the antipsychotics as a group are as well. There are many antidepressants on the market. Here's a sort of busy slide of all the different formulations that were on the market 3 or 4 years ago, but still this kind of represents a very common scenario where we have lots of different treatment choices. As we did with the antipsychotic block, I'm going to defer a lot of the discussion of diagnosis of mood disorders and their presentation and screening for them to the clinical medicine and psychiatry behavioral health team. But I think it's important to kind of differentiate depression from other mood disorders like bipolar or cyclothymic disorders that are listed here. And we're primarily in this block going to focus on depression. When we think about depression, major depression versus more minor forms of depression, sort of on a spectrum, major depression is significant, has multiple symptoms that present for long periods of time. And of all of the symptoms that present, the most concerning for us is suicidal ideation. But all of these symptoms of depression and major depressive disorder are significant to address. They not only affect someone's health and well-being, they affect their engagement in adhering to care of their diabetes, of care of their cardiovascular health, of their willingness to do the lifestyle things we ask patients with a cardiovascular history or a weight history or a depression depression comorbid with diabetes makes it really hard to manage those other health conditions as well. So as we think about it, you want to look at what the criteria are, but you also want to think, what is the impact in all realms of that person's life? As you assess patients with major depressive disorder, you'd probably want to go look at a psych history. Most clinicians in this day and age in primary care have some kind of a rating tool that's done on admission through, or assessment on an annual assessment, or when patients come in and meet a clinician. And those rating scales, they might start with a couple of 1 or 2 questions, and then if they rule in for those 2 questions, then a more in-depth rating. The Hamilton Depression Rating Tool has been one that's been used for decades with pretty good track record, but there are lots of other patient rating scales that are used as well. Assessment of patients who have major depressive disorder. In addition, you want to kind of rule out the physical exam, appropriate laboratory tests, particularly thyroid is a concern for us, vitamin deficiencies as well. And then biologically, historically, we've used to use dexamethasone suppression tests. Those are less reliable now, and I don't think clinicians typically would consider using them. But at least in history, there's been some track record of doing that. The other issue you want to look at is any medicines that can contribute to depression. Lots of things can. Anything that's a depressant can. But we also see some of the beta blockers can do that. Withdrawal from stimulants can do that. And the interferons, which thankfully we don't use that much, but use sometimes in hepatitis B, used to use in hepatitis C infection, are notorious for being correlated with major depression. The treatment options for depression should always include some degree or referral for psychotherapy and exercise. Psychotherapy works well, probably as well as any antidepressant can work. The downside to psychotherapy is it's time-consuming and somewhat expensive. And so some insurers prefer to pay for pharmacotherapy over psychotherapy because a lot of pharmacotherapy is cheaper, that doesn't necessarily make it the best decision. There's also really good data for at least mild depression to moderate depression, as well as major depression, that exercise offers benefit. In addition to exercise, outdoor activity, particularly in daylight hours for folks who have a leaning towards seasonal affective disorder, light therapy also offers some benefit. So as we talk through, and we'll focus mostly on the pharmacotherapeutic approaches in depression, just keep in mind that the best approach is probably going to be a multimodal one with psychotherapy, some degree of exercise, if there's a seasonal affective disorder component, light therapy, as well as pharmacotherapy. And then for folks who are refractory, there are other treatment options, including on this slide, electroconvulsive therapy, which is pretty much a situation that's has sort of waxed and waned in the last 40 years as far as who are candidates. But I think electroconvulsive therapy offers a benefit for folks who have significant depression and are refractory to other sort of less invasive modalities. There's also some data about, and we'll talk more about this agent in the year later in the year when we talk about surgical interventions and IV anesthetics, is ketamine. Investigationally, ketamine is associated with a sense of detachment while patients are under the influence or emerging from ketamine. And there's been at least some research data on refractory patients in major depression, refractory to everything else, that a guided dose of ketamine or doses of ketamine in a controlled environment may help with patients in their perspective of their depression and situation because of the dissociative nature of how people sort of can sort of observe things in a more objective kind of way related to that. But that's quite investigational. Our focus really here is going to be pharmacotherapy, but don't lose sight of the counseling, psychotherapy, and exercise, and to some degree light therapy as a concurrent with drug therapy. The drugs that are chosen are in part related to response rates, in part related to comorbid situations for the patient, what are the drugs the patient's on, and interestingly, what could likely be a genetic predisposition to responding to one agent over another. And so getting a family history is going to be important when you're, and we'll talk a bit about that, when you're trying to consider which agent or agents might be a good first or second line when you elect to go with a drug. Keeping in mind that the drugs we use for depression require at least 4 to 6 weeks to begin to see some significant effects. In the first week or two, some patients feel a little better about their anxiety, their sleep pattern may begin to improve, their eating patterns, their sense of overall well-being may be slightly improved, but really it's 4 to 6 weeks at a particular dose before we begin to say that we could say it's successful, and really 8 weeks before we would say, okay, this is not effective. Let's go to either an increased dose of this agent or consider a different one. And then full remission may take 3 months or more, but again, some of those symptoms may improve in the first couple of weeks. Typically, at least an 8-week trial is sort of what most clinicians would consider what you need to do before you abandon therapy or consider something else. And then what we consider a positive response is, a 50% reduction in symptoms or an improvement on a rating scale that they initially used, a significant improvement. Most folks, more than half probably, will have some response to the first antidepressant you try. But then up to half of the patients may not, and some of those may respond to a second or third agent. And just keeping in mind that, a portion of patients, 20, 30%, may not really fully respond to any single antidepressant. And so those individuals, you kind of have to look at what our next steps are, looking at all the other augmenting things we do. Certainly, as we alluded to, psychotherapy, counseling, exercise, light therapy. Are they candidates for electroconvulsive therapy? Are they candidates before that usually for adding an antipsychotic as an augmenting agent we'll talk about briefly? The other issues I think that are really important to issue, really two of them to me. One is the concurrent risk for substance abuse in patients who have depression or any mental health issue, anxiety, psychosis, anything. I think as a clinician, we are really cognizant or aware of the degree to which patients who have any behavioral health, mental health issue are at usually higher, sometimes much higher risk for self-treating with drug or alcohol as a way to manage that. And so that should be an automatic screening issue. And on the flip side of the coin, in programs that manage patients for alcoholism or for any substance abuse, those treatment programs, hand in hand, will really manage concurrently whatever anxiety, depression, other issue a patient may have aggressively. So these go hand in hand, and I think you will see this co-relationship between a behavioral health issue and substance abuse issue throughout your practice. You can't really treat one without addressing the other. The other issue for depression, which I alluded to, is the degree to which patients who have depression have higher mortality rates. And we're not talking just about suicidal ideation. We're talking about their degree to which they manage their cardiovascular disease, their asthma, their diabetes, whatever their comorbid states are, to a significant degree less effectively because of the depression. So depression, and as we allude to and sort of focus on, particularly in diabetes and in cardiovascular health, about how critical the lifestyle issues we talk about of diet and exercise and breathing and being present and all of the issues for mindfulness and those kind of issues that are critical in improving patients' health status. Patients, those conditions, all of those things may also help with depression and anxiety, but the degree to which a patient has significant depression clouding all of this is less likely to participate in all of those other beneficial things as well. So important for you to recognize, I think, as a clinician, for all of us as clinicians, to recognize that depression sort of coexists with lots of other health conditions, and the effective treatment of the depression is associated with improved health outcomes in other areas as well. Again, a study that looked at trials of depression associated with increased mortality outside of suicidal ideation or suicidal attempt. So of the antidepressants that are on the market, we'll first talk about the bottom two and sort of get them out of the way because we don't use them commonly in depression. The tricyclic antidepressants and the monoamine oxidase inhibitors. We still do use the tricyclic antidepressants mostly for lower doses for nerve pain, but because these two groups of drugs are more toxic, have more adverse effects, these are really sort of drugs of later or last resort. We don't really use these drugs very often for depression anymore. But right at the top, about 3/4 of patients eventually will have some benefit from an antidepressant, and about half of those folks will, in a sense, almost completely recover. But it's kind of hard to discern with the data that's published with varying modalities the degree to which the concurrent behavioral health, psychotherapy, counseling, exercise, other modalities contribute to that success rate. The three groups we will talk about more in depth are the selective serotonin reuptake inhibitors, or the SSRIs, the serotonin norepinephrine reuptake inhibitors, the SNRIs, and then some of the agents that sort of work sort of in an atypical kind of way, but similar to the top two agents, what we'll call here atypical antidepressants, but sometimes go by different terms. So let's first talk about the older agents, the tricyclic antidepressants and the monoamine oxidase inhibitors. The tricyclic antidepressants, the earliest ones being imipramine and amitriptyline, were first used in the 1960s. They affect the reuptake of norepinephrine and or serotonin, and they, like other antidepressants, have their beneficial effects in 2 to 6 week time frame, but they are highly antimuscarinic, sedating, orthostatic hypotension. They bind to all those receptors we saw with the older typical antipsychotics. They're associated with weight gain and seizure risks, so they're problematic. Classically, we're focusing the therapeutic effects on their reuptake in the central nervous system of norepinephrine or serotonin, leaving more norepinephrine or serotonin in the synaptic cleft longer, which is associated with improved symptoms of depression. But they are antimuscarinic. They bind as antagonists at the alpha-1 adrenergic receptor, leading to orthostatic hypotension. They bind to histamine receptors, causing sedation and weight gain. And so they're really drugs that are associated with other kinds of problems. In addition to all the problems we just noted, on top of that, these drugs prolong QT, sometimes significantly. In an overdose, they are fatal with ventricular arrhythmia risks. They also, as with some of the newer antidepressants as well, almost all of these are associated with sexual dysfunction. That could be either a loss in libido or interest in sex, but often what you'll often see with them as well is dysfunctional. Inability to have an orgasm for men or women, erectile dysfunction for men. So they're pretty common to cause that as a side effect. What's difficult whenever we think of sexual dysfunction with antidepressants is this a function of the drug or is this a function of depression? Or probably more likely both to some degree. And then we also worry with the tricyclic antidepressants for seizure risk. Now, you'll see that when we get to the newer agents, sexual dysfunction becomes an issue in consideration of one agent over another, and seizure history also comes into play as well. But most of the other side effects that are listed here are less of an issue, maybe with the exception of QT prolongation with some of the SSRIs, and we'll come back and talk about that as well. Of the tricyclic antidepressants, there are the tertiary and the secondary amine tricyclic antidepressants. The tertiary ones, amitriptyline and imipramine, they are sometimes used in low to moderate doses for pain, neuropathic pain, but they are highly antimuscarinic. And so they cause all of the anticholinergic side effects we've talked about with urinary retention and confusion and constipation and the like. And so they're really troublesome drugs for a lot of patients. And they are fatal in overdose. So again, not great choices. If a clinician is considering a tricyclic antidepressant, even in low doses for neuropathic pain, more often they're going to pick one of the secondary tricyclic antidepressants, which have less antimuscarinic properties, either desipramine or nortriptyline. And so those are sometimes considerations for neuropathic pain over the older amitriptyline and imipramine. Here's a chart that kind of compares all of these agents by their sites of action and some of the other properties they have. But again, the tricyclic antidepressants outside of neuropathic pain are less commonly used, and the ones that are in red here are the ones that you may see more often for neuropathic pain. Similarly, the monoamine oxidase inhibitors for depression are a rare event. You will not see these often. If you see someone on one of these medicines, particularly Nardil or Pornate, that should be an immediate stop and check for drug interactions and any risk for serious consequences for adding or subtracting other drugs on board with monoamine oxidase inhibitors, because the monoamine oxidase inhibitor will inhibit the degradation of norepinephrine, serotonin, and dopamine and can result in sometimes life-threatening complications. So we'll talk about those. The monoamine oxidase inhibitors really are almost last resort. And we have to stop all the other agents that affect norepinephrine or serotonin or dopamine when we use these drugs. So people need what we call a washout period of their other antidepressant. Make sure all their other antidepressant is out of their system before you start these. So this is a rare event. I think in the last 5 years, I've seen maybe 1 or 2 patients come in the hospital on one of these agents. That's a pretty rare phenomenon. So you would not, as a clinician, I think, be doing this without a clear guidance from someone on the behavioral health team that has explored with a patient who's explored many other options with no success. These agents inhibit one of 2 subtypes of monoamine oxidase, either type A or type B, and by inhibiting monoamine oxidase, it leads to less breakdown of these neurotransmitters and therefore potential for increased benefit for the depressive symptoms, but also hypertension and other problems. The adverse effects you can see are either hypotension because of this inhibition and the feedback loop involved, or with a significant interaction, the real concern is hypertensive crisis. So hypotension based on autoregulation with low-dose MAO inhibitors at the onset, but with drug interactions sort of like hypertensive crisis, significantly so. Also, the risk for serotonin syndrome, which we'll talk about briefly, insomnia, liver toxicity, weight gain, and sexual dysfunction are problematic. On top of that, there are significant interactions with anything related to tyramine. And tyramine would be in a lot of fermented foods. And if you think about going on a picnic in Paris or classic French picnic basket, most of the things in that classic French picnic basket would be a problem with monoamine oxidase inhibitors. Some of the stronger fermented cheeses, fermented meats, salamis, pâtés, a number of wines, particularly Chianti and red wine, broad beans can be a problem, all containing tyramine, or even microbrew beers, and I'm not sure about ciders, but can be really sort of problematic with fermented, highly fermented foods. The mechanism here, if you kind of look at sort of the monoamine oxidase and how it involved in tyramine getting in out of the cell, the larger intake of tyramine in food ultimately leads to much more norepinephrine production because the inhibition of the monoamine oxidase that would break down norepinephrine in the cell. And therefore, you're really concerned about this as being a significant problem. Here's a list of some of the foods that would be restricted. We'd avoid all the things that are fermented, aged cheese, herring, broad beans, yeast extracts, and be really careful about all the kind of fermented kinds of foods. And microbrew beers are, because the yeast products and yeast extracts can be really problematic. And so the tyramine content in any of these foods can sort of vary based on how they're processed or made or available, and so we want to be really sort of careful about that. And then anything that is a stimulant that involves norepinephrine or epinephrine or dopamine or serotonin would be really problematic. So there's a whole host of medications that would affect the sympathetic nervous system here that are considered contraindications for use with MAO inhibitors. The two that are listed are here that are been on the market for decades are Nardil and Parnate. Again, I think the big issue for you is if you see these drugs on anyone's med list, that should have you stop immediately to run a drug interaction check and check with a couple other people about what you're starting and stopping for therapy and how that could impact their response. There is a sort of a MAO type B inhibitor used for Parkinson's that conceivably can be used for depression as well as a patch, a transdermal patch, selegiline. I'll tell you quite honestly, I do not see this agent used in practice, but it may on occasion be used. Here's where I think the energy should be spent, though, for our discussion of the antidepressants. Are the SSRIs, the selective serotonin reuptake inhibitors, the SNRIs, the serotonin norepinephrine reuptake inhibitors, and then a couple of other agents that are kind of related to them as well. Let's start off with the SSRIs, the selective serotonin reuptake inhibitors. And these were first available in the mid to late 1980s and were really came to bear and then maybe in the 1990s. And they are still considered the mainstay, probably first line for many situations in primary care. They work on inhibiting the reuptake of serotonin, and as such, they are associated with sort of pretty good track record for reasonable efficacy and overall safety in most patients. There are a number of different SSRIs on the market, and we'll kind of differentiate among them. But for the most part, we see their adverse effect profiles are similar but not identical. And we find that even though the mechanism is the same for the most part, they may have subtle differences in the subtypes of serotonin receptors where they are most effective. And so we sometimes find that a patient who doesn't respond to one SSRI may respond to a different one. And if we get to the point where genetic profiling offers sort of a real strong correlation with efficacy and safety, expect that in the next decade or so, genetic profiling may really help us to determine which agent is ideal to start with a patient. But right now, a patient's family history of and questioning the patient, for example, if they are a candidate for an antidepressant, have they had a family member, particularly a first degree relative, who has been on antidepressants or responded to a particular one, and that all other things being equal, if it's not a contraindication for that patient, might be your first sort of genetic assessment for that patient of which agent may have a better track record. So here are the common SSRIs that you'll see in practice. The generic names listed across the top: fluoxetine or Prozac, sertraline has been around for a while. Paroxetine or Paxil has been around for a while. Fluvoxamine, not all that commonly used. We only use it for obsessive compulsive disorder. And then citalopram and escitalopram. And of all of these, the agents I see clinicians sort of reach for the most, I think, at least in this day and age, is probably escitalopram. Still see a fair amount of sertraline and some occasional fluoxetine. Paroxetine has advantages. Paroxetine has some good data in depression and maybe in post-traumatic stress patients, but paroxetine is probably the most dangerous to consider in a patient who is pregnant or could become pregnant. So paroxetine is probably, of all of the agents, maybe of all the antidepressants on the market, is probably the one you want to avoid in a woman of childbearing age. They vary in their half-life, and some of these agents have active well, one of them does. Fluoxetine has an active metabolite, norfluoxetine, that hangs around for weeks. But the rest of them, fairly short-acting, dose typically, most of these are dosed once a day. And the dosage ranges vary, but they are used for depression, and many of these also are used for anxiety as well. The side effect profile, generally pretty well tolerated. They'll have a lot of GI complaints patients will have, and depending on the agent, maybe some other side effects. But the GI effects often are uh, nausea, maybe vomiting, that's not common, but abdominal cramping and diarrhea when we start it. So usually what we'll do with these agents is to consider starting on a low dose if we can and escalating up to the dose we want to see people on, and then go from there. And patients usually tolerate that pretty well. Similarly, when we're stopping these agents, there is a clear withdrawal syndrome that patients have, particularly when they use a shorter acting drug. And it's not a terrible withdrawal, but it's kind of uncomfortable. Patients feel often have mild GI complaints during withdrawal, maybe aches, pains, and feeling almost like they've got a very mild case of the flu. And the way we minimize that is to taper withdrawal when we need to as well. Sexual dysfunction, pretty common with these drugs, but we don't usually make a big deal of that because patients, may not notice that, or they may, but it's pretty common. And then we'll talk about bupropion in a bit. That's the only antidepressant that is not associated with sexual dysfunction. If anything, may even help that matter. But hold off on that. We do worry about this thing called serotonin syndrome, when someone gets too much serotonergic activity, in both inhibiting the reuptake of serotonin alone or in combination with other things that affect serotonin can pose a risk for this, and we'll talk about that in a bit. There have been very, very rare reports of extrapyramidal side effects that we saw with antipsychotics with the SSRIs. But I have to tell you, in all honesty, in clinical practice, I don't think I've ever seen or observed this to any appreciable degree. And so I think we keep it in mind, but I would sort of suggest that it's likely a patient who's on a combination of an antipsychotic and an antidepressant who would exhibit this much more than just the antidepressants, particularly the SSRIs. Finally, we do have to worry about QT prolongation with the two agents citalopram and escitalopram, and we have dosing caps for older patients because of that QT risk, as well as watching anything else that prolongs QT. So we're going to be aware of that. But short of the QT prolongation risk, these drugs are really safe in overdose and renders these as first-line agents even for patients with suicidal ideation. And even then, I don't know that clinicians necessarily would avoid citalopram or escitalopram in a patient with suicidal ideation, but at least in theory you might because of the QT prolongation risk. But the other agents in the SSRI class are really safe in overdose, or at least safer, let's say that, compared to the older agents, the tricyclics and the monoamine oxidase inhibitors. SSRIs are also used in children. The agent probably has the most data there is fluoxetine, that's been on the market the longest. There's some question about whether growth hormone may be affected, and so would watch growth curves in individuals, but that's going to be a concern. The other thing we'll talk about in children and in adolescents is that children, adolescents, and young adults have a higher risk for suicide and suicidal ideation with these agents than do older patients. And we'll talk about that in a bit. So we do kind of worry about that. But that's true across the board, not just for the SSRIs. There's also data for using some of these agents, particularly fluoxetine, for premenstrual dysphoric disorder. And so there's data for that, using it either daily or for the 2 weeks before menses for women who have this as really debilitating symptoms for premenstrual dysphoric disorder. This is not for everyone. But again, that might be a consideration. If a patient has both depression or maybe anxiety and premenstrual dysphoric disorder together, then maybe the combination of those presentations makes them a better candidate for fluoxetine particularly. So consideration. Another real consideration for us in practice is, as we alluded to, depression and diabetes, depression and cardiovascular. Depression post-heart attack, post-MI, is very common. About 1 out of 5 patients will have significant depression post-MI. And untreated depression increases the mortality risks associated with post-MI patients. So clinicians have had long questioned, okay, so which therapies are safe to give in a patient who has had an MI, and the SSRIs in general, and the SNRIs to some degree, have been tried and tested in cardiovascular risk, and short of QT prolongation are probably safe choices post-MI. Certainly, we would not want to use the tricyclic antidepressants or the MAO inhibitors. So treating depression in post-MI patients is important, and using an SSRI is probably advantageous. Even as citalopram and citalopram are not considered to have significant cardiovascular toxicity, even though they can prolong QT, I think most clinicians would kind of look at their QT, and if the QT is okay, wouldn't worry about cardiac toxicity per se with escitalopram or citalopram. The other side effect profiles are pretty well tolerated again with the SSRIs, and what renders these drugs really good choices for treating depression.